My name is Brian Earp. I'm an associate professor in the Center for Biomedical Ethics and also have a joint appointment in the philosophy department. It's my great pleasure to introduce Peter Singer today. Now, of all the speakers who might come to NUS, it is true of this speaker that he is one about whom it can truly be said he needs no introduction. But nevertheless, I'm going to say a few words of introduction, not least of which is because Peter asked that I mention his podcast, which you all should be listening to. It's called Lives Well Lived, so you can get that wherever podcasts are available. Peter's been called the most famous world philosopher living today. I think that's true. Certainly he's been influential in the thinking of many people in this room, including my own. Faisal mentioned that his decision to become a vegetarian was directly inspired by reading the book Animal Liberation. So Peter's been involved in many areas. More recently, we've been looking at artificial intelligence and a lot of the novel ethical issues that are raised by this powerful new technology. And today, Professor Singer will be giving a more general talk about why ethics is essential for the healthcare professions. This talk will be about an hour, including Q&A, and then afterwards there will be about half an hour with some snacks out front for milling about and networking with Professor Singer, so do stick around for that, and that'll be just out in the lobby here. So with no further ado, please welcome Professor Peter Singer.
Thanks very much, Brian, and thanks for the plug for the podcast. Once we get big enough to reap in thousands of dollars in advertising, you'll get a cut. Don't hold your breath. Good. So we're talking about why ethics is essential for the healthcare professions, and let's look at an outline of that. Well, we will if the clicker works. Yes, whoops, it does work. Okay, so this is what I'm going to talk about. What is ethics? For those of you who don't know, I assume there are some people in the room who haven't studied ethics formally, are they? Well, if not, you can skip this. Then we're talking about different levels of way we do ethics, traditional and contemporary approaches, contrasted, and then I'm going to talk the more applied bit is about some of the ethical issues in healthcare, and there's so many I could have picked a whole lot, but I'll just give you some, for example. Good. So, what is ethics? Well, that term can mean different things. One thing it can mean is a set of standards for guiding conduct. Then it's just a synonym, more or less, for morality. Often people ask me what's the difference between ethics and morality. And in one sense of the term ethics, my answer is there isn't really a difference. There used to be a difference, my sense that ethics was used more narrowly in the second and third senses that I have here. But I think today ethics has come to be used really as a synonym with morality. Slightly different connotations maybe, but still more or less the same. Secondly, ethics can refer to a specific code of conduct. So if we talk about medical ethics or journalist ethics or whatever else it might be, nursing ethics, business ethics, then that's something usually that is written down or that is understood by everybody within that group, and you should follow it, at least other things being equal. And thirdly, ethics was regarded as a term for a branch of philosophy that deals with the kinds of things that I've been talking about, that deals with assessing conduct, what's right, what's wrong, what we ought to do, what we ought not to do, what's good and bad. And that, I think, was the standard meaning of it. And it still is. There's lots of courses on ethics. So that's another possible sense of it. Okay. One thing that I want to say about ethics for those not familiar with it is, I think, the importance of the distinction between facts and values, between is and ought. This is David Hume, the 18th century Scottish philosopher, who famously observed that in lots of arguments, people start off with describing various things about the world, for example, saying there is a God, or making observations about human nature. And then suddenly the argument switches to, therefore, we ought to do something. And Hume said, this is never explained how we can get from these statements that are joined by is to a statement that is joined by ought. And although there's always room for interpretation in philosophy, my reading is that he thought you can't actually do that. It's true that there are some passages where Hume himself seems to be doing that, not about there is a God, but about observations on human nature. But generally he's taken as an important figure in emphasising this distinction. And I do think it's important in understanding ethics. We can, of course, describe ethical systems in the senses which I was talking about before. We can describe what in various societies, anthropologists might do this, what in various societies are the standards that people praise people for doing certain things and blame them for doing others. So what are those standards? They vary to some extent from society to society. So yes, we can describe ethics, but if we want to make ethical judgments about what is or is not right or wrong, we can't simply derive them from the factual statements. That's the claim I would make anyway. No moral judgments logically follow from factual statements. So ethics, when we're doing it, is a normative activity. That means it's action guiding. It's telling you things about that should guide your action. It's not simply a description. Okay, so again, for those who don't know the subject, three main areas of the philosophical subject of ethics. We start off with meta-ethics, which is, as the term meta here is used to say this is something, it's not exactly ethics itself, but it's about ethics. Something like the same sense in which metaphysics is about physics. You're saying what is going on in physics, what are the ultimate realities that we're looking at. So, so meta-ethics asks questions like, are there objective truths in ethics, or are we simply expressing our preferences? And there's widely varying philosophical views on that, from those who think that we are just expressing preferences. It's as if we're saying boo for this and hooray for that. And there's no scope really for arguing, or not much scope for arguing on that view. And then at the other end, there are those who say, no, we're stating normative truths about the world. Derek Parfit, for example, a famous Oxford philosopher who died about 6 years ago, I think, maybe a bit more, and Thomas Nagel, who's still around, are proponents of that. And although I didn't initially defend an objective view of ethics, I have for the last decade or so. So that's what the debate is about in meta-ethics. Then we have normative ethics, which refers to large-scale discussions of criteria for what is right and wrong, or how we ought to act. So large-scale in the sense that they're broadly applicable. So, for example, the utilitarian will say, the right thing to do is the thing that does the most to increase the net surplus of happiness over misery, if there is such a surplus, or to reduce the net deficit of misery over happiness, if there is a surplus of misery over happiness. And so that can apply to all conduct. There might be some rules or things within that you might want people to follow, but it's very general. And something similar can be said for Kantian approaches to ethics and natural law ethics, the tradition that's strong among Catholic theologians. There's systems that apply generally, and philosophers will talk about which is the right system to use. And then what I'm going to be talking about for the rest of this lecture is practical or applied ethics, which deals with questions about what we ought to do in specific real-world situations. And again, some of practical ethics might be somewhat broader. We might try to set standards for what, let's say, doctors or nurses ought to do in a range of situations, but it may also deal with quite concrete, even unique situations. Good. Now, before I go further, I want to convince you that practical ethics is important, and it's important because it changes lives, and we just had a nice example of that, thank you. If my writing about the moral status of animals has led somebody, even in this room, to change what they eat, that's anecdotal, of course, but it's one example of how practical ethics changes lives, and there are quite a few people over the years who've told me that. Some who've told me that my views about what we ought to do to help people in extreme poverty have changed their patterns of giving and the amount that they're giving. But those are all anecdotal, and so I wanted to just give you these references if you want them. I'm not going to go into the details. But a few years ago, Eric Schwitzgebel, who's an American philosopher, best known for studies which showed that professors of ethics, professors of moral philosophy, did not behave any better in various situations than people who were professors of some completely different discipline. They were the control group. So he was inclined to think that philosophy doesn't make a difference to how people live. But he knew that I had a different view and had some, as I say, anecdotal examples. So he invited me to join him in a sort of study, a test case, in his own university, the University of California at Riverside. And he pointed out that it was particularly well suited to test this theory because, firstly, they had very large introductory philosophy classes, about 1,000 students in that class. Secondly, the students nearly all ate at a university-run cafeteria. They got their lunch there anyway. And thirdly, they used their student ID card to buy their lunch. And Eric had talked to the people who ran the cafeteria, the catering service, and they had said, subject to institutional ethics committee approval, yes, we could tell you what meals the students are ordering or what meals particular ID cards are ordering. So Eric thought this was a great opportunity to show, as I said, as he expected, that teaching a class on the ethics of whether we ought to eat meat or not would not make any difference to students' behaviour. So I accepted the challenge, and Eric also brought in a colleague of his, Brad Coaklett, and we ran the study, and I'm delighted to say, so we had a control group, I should say, so half of the students in this class got a discussion session on the ethics of eating meat, and the other half got a discussion session on the ethics of donating to help people in extreme poverty. They were just the control group. We didn't attempt to measure whether their donations increased. But I'm delighted to say that in those who were in the ethics of eating meat discussion groups, there was a statistically significant decline in meat eating after the class. And that went on for some months, and then it was interrupted by COVID, which was a bit of a nuisance, so we didn't continue that. But we did run a follow-up study which sort of confirmed that outcome. So, and then this third study here was not anything I was involved with, but it was also a study of eating, and it was in a sort of college situation where the students ate in a dining hall, and it was not related to the ethics of how we treat animals, but to the ethics of climate change. And the students were informed about the contribution that meat makes to global warming. And there was also a statistically significant decline. Now, you know, this doesn't mean that all of the students changed their diet, far from it, but enough did to make a detectable difference. So practical ethics is important, and there's not too many subjects in your curriculum that you can say, you know, non-professional subjects. Obviously, if you're a medical student, I hope your course will change your life and you will practice medicine at some point. But of other courses in the humanities particular, there's not many subjects which you could say that. Okay. That's not what I meant to do. So, this is a slide about the traditional approach to medical ethics. And in case you think I'm talking about, centuries ago, I'm talking about when I started doing bioethics, which was in the 1970s. And especially in medical schools, this is essentially what the situation was like. The senior doctors were the authority figures. They were sometimes referred to, if they were also professors, they were referred to as the God professors. and you didn't really criticize them, or at least the medical students were not supposed to criticize them, nor were their colleagues really, in terms of their ethical behavior, because they might criticize the science if they didn't like the science of something that they were researching on. But in the sort of hospital setting, they were not to be criticized. And if they were criticized, there was a kind of a professional bond, so the profession rallied around them. And the medical practice was also, by today's standards, quite heavily paternalist. So there were no real rules. They were just starting to get some rules about the requirement of informed consent before you operated on a patient. And the senior doctors would know best, so they would, even if they talked to the patients about why they were doing something, they weren't really asking the patients to consent. They were telling the patients that this was what needed to be done. As for the students learning medical ethics, that was done at the bedside. So the students, in their later years of their course anyway, would be working in the hospital as interns. They would be doing the grand rounds with the doctors, and they would observe the way the doctors behaved with the patients, and they were supposed to absorb the ethics from that. There was no real separate discipline of bioethics or reflective discipline in which people with some experience in thinking about ethics, teaching ethics, were teaching medical students. There might be a few weeks that they did which included some medical ethics, but really the point of that was to say, this is how you stay out of legal trouble. So it included things that you ought not to do if you were going to stay away from the law. So traditional ethical views in that system, as you can imagine, were passed on pretty uncritically from the seniors to the juniors, who then eventually became seniors and passed them on. The Hippocratic Oath was taken in a variety of different forms, but it was referred to sometimes among opponents of abortion because it includes this line down here, that you won't give medicine to a pregnant woman, and also because there was something about I'll administer no poison, it was used as a buffer against suggestions that we could legalise voluntary euthanasia. But otherwise, the other bits of it were ignored, like there's a line in it about how the doctors who teach you and their sons will be like brothers to you. So various kind of keep this all together in the group, which were basically ignored. And as far as the position of nurses were concerned, there was really no discussion of ethics for the nurses because the doctor would simply tell them what to do, and they were not expected to think for themselves about any ethical matters. Although from conversations with them, some of them certainly did, at least in Australia where I was. Nursing at that point was not a degree course either. You didn't go to university. You went to a sort of teaching college, and there was no ethics taught there. Okay, so things have changed a bit. One thing is that I think there's generally more of an emphasis on a healthcare professional team working together, and that means that if there are ethical sensitive decisions made, the team will get together and discuss them. So I remember showing my students a few years ago, would be quite old now, a film about the treatment of a severely disabled, actually there was a pair of very premature newborns, one of whom was going to be severely disabled because that child had a massive hemorrhage in the brain, and they were both on a respirator because they were premature, and the doctor was talking to the parents about removing the child from the respirator, which at first they were reluctant to do, And there's part of that film is a discussion among the team with the nursing staff contributing to that. Very often, of course, the nursing staff know the patients better than the doctors because they spend a lot more time with the patients, a lot more time talking to the patients. So obviously, as in this film, they may have useful contributions to make on any issue in which the patient's views are important, and that's most of the issues that, the medical issues that one's concerned with. So that's a big and important change. Also, of course, other healthcare professionals are now degree courses, and so ethics is part of those courses, as it is part of medical courses, and taught by people, generally, still not always, people who have some training in ethics, not simply by people who are medical professionals. In fact, typically it used to be that the people talking about medical ethics were people who were older lecturers in the medical school who were no longer doing research but were talking about ethics, which again they felt they had absorbed through their practice. But I think often the standard that was being taught was not very well informed about ethics. Obviously, the informed consent of the patient is now an important part of of carrying out medicine, particularly surgery and other procedures. And at least under some circumstances, in most, not all countries, abortion is a part of healthcare. Oops, that's back again. Okay, so let's look at some issues in bioethics. At the time when I started teaching in bioethics, I was at Monash University in Melbourne. This was the major issue of the day, in vitro fertilization. This is Louise Brown, the very first baby to be born who was conceived outside a human body, and that was 1978. And there was a lot of discussion of that. That happened in the UK, the team of Edwards and Septo. But there was a lot of discussion in Australia because the Monash University medical team was right up there just behind the UK team. So the second child to be born from in vitro fertilization was born in Melbourne. And various other breakthroughs were made by the Melbourne team, including showing that you can freeze and thaw an embryo without harm to the child. So that was a major issue, and it's interesting now looking back on it, how controversial it was and how to look at some of the arguments that were put up against that. Some of these arguments were put up particularly by people, religious people, most prominently the Roman Catholic Church, but also some Protestants. And if you look at these arguments, particularly the first one, I don't think it would be taken very seriously as an ethical argument against IVF today, but that, of course, was how the sperm was obtained, and the Catholic Church thought it was wrong. And it was an interesting example, I thought, because it seemed like the rationale why the Catholic Church thought masturbation is wrong would be that you're not going to have children. It's non-reproductive sex. So if they're against contraception, they could be against masturbation because you're having sex without the possibility of reproduction. But when masturbation is required for reproduction and the couple couldn't actually have a child without it, they somehow seem to be stuck with the idea that it was still wrong and you shouldn't be doing it. And so there was this view, the second of these points, they had that just as they said you shouldn't have sex without at least being open to the possibility of conception, so you shouldn't have conception except through sex. Then others, again, of course, the Catholic Church was prominent too, but there were others here who was concerned about the embryos as potential human beings. And when you undertook IVF, particularly in those early days, to maximise the chances of producing a viable embryo, women were typically given fertility drugs and would multiply ovulate, and then some of the multiple embryos were also transferred, and if the embryo took, then what were you going to do with the other embryos? Or even before freezing was demonstrated, the other embryos were not going to survive anyway, the ones you didn't transfer. So some of them thought this is wrong because you're creating embryos, most of whom are going to die. It was pointed out by some of the medical people that happens in nature as well. It's quite common that an embryo will be conceived during sex but will not implant in the uterus and will miscarry at a very early stage, so early that the woman may not notice that she ever was pregnant, that she ever had an embryo within her. So it wasn't really all that different in terms of the ratios with IVF. There was this question, though, about what to do with the surplus embryos, especially once freezing came in too, then they were viable. So there was a problem of, well, this couple have got half a dozen embryos frozen and they've been successful in having a child or in having 2 children if they wanted, the number of children that they wanted to have. What are you going to do with the surplus? And there are a couple of possibilities. One is you could donate it to other couples who could not produce an embryo. A woman, let's say, was not producing eggs, and that was done with some of them, but there weren't really enough takers. And the other suggestion was that they could be used for research, which of course would destroy them, and sometimes that research was going to take stem cells from the embryos and destroy them as well, which is a further issue. So I'll come to that in a moment. Then I think perhaps one serious objection, at least at first, was the thought that IVF would lead to abnormal babies. The embryologist who was at the Monash University team, Alan Trounson, had come to it after years of work with cattle. So if you have particularly valuable cows and bulls, then you can do embryo transfers, you can get more valuable offspring than you would if you simply used artificial insemination, where you would only be getting it from the male. So he had done that quite a lot, and he was therefore pretty confident that there were no extra abnormalities, but maybe humans were going to be different. So I think there was some risk, maybe there was some small risk of that, but it was perhaps outweighed by the desirability of enabling infertile couples to have children. And then the other issue, which is a more general one, is what further possibilities was it going to lead to make possible? And let's look at the next slide. Here are some of those, quite a lot of them. So it makes a possibility of surrogacy. Now, there was surrogacy before in the sense of couples who could not have children could use artificial insemination to have a child with a surrogate, where the child would then be the man's genetic child, but not the woman's genetic child. Once you had in vitro fertilization, you could donate the embryo, implant the embryo into the surrogate, and you would have a woman bearing a child to whom she was not genetically related, which again had never happened, and for some people made a difference. So it made surrogacy more desirable for some people than it otherwise would have been. I've already mentioned the freezing and thawing of embryos and the fact that they can then be used for research to harvest stem cells, or possibly it may be possible to grow them on longer to the point where they have organs that could be isolated and grown for transplantation. That's not being used yet, but it might be a possibility. And then there's the genetic modification and selection issues, which I think are serious questions which we are still grappling with, or some people are still grappling with. Once you have embryos outside the body, you can genetically modify them, as Jian Qiu did, for which he violated various procedures in doing this, apparently. He wasn't punished for the genetic modification as such, but for not following proper procedures with the ethics committee and with informing the parents properly. Actually, I've co-authored a short piece on that with Julian Savulescu, in which we argue that it was unethical because it did have some risks to the children, and it was not dealing with a life-threatening condition. I mean, it was protecting the children against HIV, which there was some risk that they could have because the father had, but you can treat HIV with retrovirals if they do have it, and there was a significant risk of abnormalities. So our argument was not that genetically modifying embryos is wrong, but that you should start with lethal genetic defects where there is no long-term survival, and then you could prove the concept, and if you could get successful results with that, you might then later move on to serious abnormalities, but not invariably lethal ones. So that's one possibility, and then we have this issue of creating multiple embryos, which, as I said, was being done anyway, and genetically testing them to avoid genetic defects. Let's pause there. And that's something that is being done with couples who are at risk of having a child with a genetic defect. But it would also be possible to select for more desirable characteristics. And Julian Savulescu, as many of you know, has argued in favour of that, the concept of procreative beneficence, that it's a good thing to have enhanced children, if you like, if we are making them, whether it might be at the upper end of the intelligence range of the kinds of possible embryos that we can have, or maybe on the scale from severely depressed to kind of inanely cheerful, to be somewhere a little bit above the average cheerfulness. Those might be good things that we can do for our children. So that argument is, why not? But generally speaking, I think people are still arguing against that. And of course, having embryos, having in vitro fertilization makes cloning humans possible. But as far as anybody knows, that hasn't yet been done. Since it's been done with other mammals, it's possible it could be done with humans. Okay, let's move on to another issue. What do you do when parents and doctors disagree? This is again something that I worked on with Julian. This is we're talking about the case of Charlie Gard, an infant born in 2016 in the UK with mitochondrial DNA depletion syndrome, a very rare genetic condition. And the doctors in the UK said there's really no hope for this child. We should remove the respirators and allow the child to die. The parents said, no, we want to try whatever we can. They found a doctor in the United States who said he was willing to do some experimental treatment. And the parents then crowdsourced and raised funds to be able to do this. But the doctors in the UK said, no, we think that that's cruel, that it will inflict further stress on the child. It wasn't clear how much Charlie Gard could actually feel, by the way, with the abnormalities that he had. But the doctor said, no, it's futile and cruel. And it then went to court because the parents took the hospital to court, and it went through various court hearings, so it actually dragged on for quite a while. And Charlie Gard did live 11 months before finally the courts agreed with the doctors and allowed them to remove life support, and Charlie died. But the general issue here is who should have the say in these sorts of situations. And sometimes the situations will go the other way. I mean, in this case, sometimes the parents might want the child to die because the child has an abnormality, but the abnormality might be compatible with life. So it could go the other way. The hospital thinks you ought to treat the child, and the parents say, no, we don't want a child with that disability, even if we agree that the child could live and not be as totally, with a totally lethal defect. So I think those are important issues, and I tend to think that the parents' views should have a lot of weight in both directions, whether they want the child to live or to die. But I suppose there could be a case where the prospects were so futile and the suffering of the child would be so prolonged that I would not side with the parents. But I'm doubtful that this is such a case. I'm doubtful that it would have been such a burden for the baby, even if you assume that the baby could feel things as a normal baby could. There's no particular reason why the baby couldn't be kept sedated and comfortable during the journey to the United States and whatever the treatment was. Okay, resource allocation is a big issue in healthcare ethics, and I think the pandemic gave us some interesting examples of that. In particular, this question of who gets a bed in the ICU. The standard view pretty much everywhere was it's first come, first serve. You don't try to select people in the ICU on the basis of their medical prospects or their condition. As long as the ICU bed will help them, as long as it's positive, it's not futile, then you admit them to the ICU if you have a bed at the time that they present. And again, as long as the ICU is continuing to help them and the treatment is not proving futile, they will stay there even if somebody else turns up with more urgent situation or for some reason a better prospect. But during the pandemic, when hospital beds filled up, at least in some countries and in some units, the ICU directors changed this policy and started to essentially triage people, patients. That is, if you were likely to survive anyway without going into an ICU, then you didn't, even if it might have slightly increased your survival. If you were going to die anyway, whether you went into an ICU or not, then you didn't go into it, and maybe that would have happened anyway previously if it was really clear that you were going to die. But in the pandemic, even if there was like a higher chance that you were going to die and somebody else needed the ICU treatment but had a greater chance of survival, they would go in. And also, and more controversially, the number of years of good quality life that the patient could expect to have if they were admitted to the ICU were also a factor. This was sort of explicitly discussed in northern Italy, which was the first place to have a major COVID outbreak outside China. It was sort of published there, and then a year or two later, the National Bioethics Commission of Italy said, no, you shouldn't have done that. But by that time, things had eased a bit anyway. And it was particularly controversial because of the age, the fact that older people were less likely to be admitted. This is somebody from a Centre for Aging Better who was quoted in the media as describing it as a dangerous knee-jerk ageism. But actually, I don't think that kind of ageism is knee-jerk or discriminatory, despite the fact that I'm now in that age bracket where I wouldn't get admitted under that policy. Because after all, it's a different kind of discrimination, I think. I mean, discriminating against someone on the basis of race or sex seems obviously wrong because that's going to, that's them are going to have a worse life because of that all through their life, whereas those in the more privileged groups are going to have a better life. But we're all going to get old, hopefully anyway, and those who do get old have been young. So it's not discrimination in the same way. It gives everybody maximum chance of living to a good old age. So in that sense, it seems to me a fair practice and one that should be used if, in fact, there aren't enough ICU beds. Okay, another thing that came up in the pandemic was human challenge trials. Fairly early in the pandemic, before there was a vaccine, a guy called Josh Morrison, who had been involved in the effective altruism movement, set up a website calling for volunteers to be challenged by candidate vaccines. So the idea of a human challenge trial here, if you're not familiar with it, is that there are various possible vaccines. We want to know how effective they will be. So you give different vaccines to different fully informed volunteers. And then when the vaccine has had its effect on them, you deliberately infect them with the virus. Now, COVID is not a lethal virus, uniformly lethal virus, and particularly in younger people, the rate of lethality was extremely low, still is extremely low. So it was mostly younger people in their early 20s who volunteered, but actually somewhat surprisingly, the website, which is called One Day Sooner, based on the idea of if you get the vaccine just 1 day sooner, you'll save lots of lives. At the height of the pandemic, you would save thousands of lives for every day were being lost. If you get it 1 day sooner, you've done a good thing. So there was something like 35,000 volunteers from many different countries registered. In fact, it wasn't used to develop vaccines. There was too much hesitation and resistance. Many people said, oh, I'm not sure if it's ethical. Are they really fully informed? And so on. But as this quite recent article in the New York Times, I didn't put the date on it, sorry, but this was just this year anyway. This article appeared in the New York Times. They're now being practiced more frequently in various ways. So I think that that's a good thing. I think if people are fully informed and choose to volunteer, that's excellent. They're doing something really good for the world, and we should allow them to do it, and it can certainly speed up vaccines in other situations or make other improvements in medical treatment. Okay, I don't want to go too much over high, so I'm going to speed up a bit. This is a big issue that I've been interested in for a while. And I start by asking, why is it normally wrong to kill another person? And here are some reasons. It may violate the person's autonomy. It thwarts their desire to go on living. It deprives them of positive experiences. And it causes grief to those who love that person. But there's circumstances in which none of these things really apply. And that's when somebody is terminally ill and requests assistance in dying, because they then have judged that, so it's their autonomy that's up there. They're making that autonomous choice. They don't want to go on living, so you're not thwarting their desire to go on living. It's not depriving them of positive experiences, or at least they're going to have more negative experiences. That's their estimate, and they're the best judge of that, typically, I would say. And although their death will cause grief to those who love them, their death is coming fairly soon anyway. And generally, their families don't want to see them suffer. So that's... okay, I'll just flip over. I think I'll flip over that slide, otherwise I run out of time. This is something that is now spreading, and again, just during my lifetime, during my career in bioethics, in fact, it's come to be legal. In none of these countries was it fully legal, although it was practiced in the Netherlands fairly openly by doctors going back to the, I think, early 1970s. But all of these legalizations actually have taken place in the 21st century. And you can see there's quite a lot of countries now, and parts of countries, like in the United States. Some of these, the situation is a little legally uncertain. Italy, it's a constitutional court decision, but I read that just last month, Tuscany put regulations in place, and there's some legal debate as to whether the regions of Italy can put regulations in place. The national government has not yet done so. So it's somewhat controversial. And in the UK, the legislation to legalise assisted dying got a majority vote on what's called a second reading in Parliament. I don't know if you have the same system in Singapore. And it now goes to a committee stage where the details of the bill will be worked out, but it seems very likely that the UK will have voluntary assisted dying within, say, a year. So I view that as a good thing. Again, I'll skip over this because I don't want to run into your question time. It's interesting that when you ask people why they want to use the legislation, Oregon's done good surveys for many years, it's not pain control typically. The pain control down here is 34%, and it's not the financial implications of treatment either. It's these things like loss of autonomy, can't do what makes life enjoyable, loss of dignity, and so on. So when people say, oh, if only they had better palliative care, that wouldn't be, they wouldn't be requesting this, that's apparently not really true. It's not the palliative care, pain control that can do it. Okay, and my final slide is conscientious objection in healthcare is another thing that has been discussed here in Singapore and that Julian has been involved with. He's a co-author of this book. It's, again, something that I think is important for all healthcare professionals, not just for the medical people, but for the nursing staff. Should they have a right not to participate in a practice? My answer would be yes. You don't want to force people to participate in a practice that they think is wrong. They're probably not going to do it very well anyway. But do they then have an obligation to inform the patient that other professionals are available, willing to provide the requested care? I think the answer to that is yes, although, if in fact you put yourself in the position of, let's say, a doctor who thinks that abortion is really equivalent to murder, they might have a hard time in saying, no, I won't commit murder, but here's another doctor who will. You can go to see them. So I don't think it's absolutely straightforward, but on balance, I think that's probably the right situation. Okay, thank you very much. I'll leave it at that.
Hi, good evening, Professor. My name is Justinian. I'm a year one medical student. I was really interested when early on in your speech you mentioned that you didn't always believe that ethics was an objective or that there were objective ethical statements, objective ethical knowledge, but you've since come to revise that view. Could you share a little with us why you've kind of changed your mind on this matter?
I can share it briefly. Yes. So the view that I held was that essentially, I had a slide of David Hume there, and I talked about the is-ought distinction. Hume had a view about reason too, which is that practical reason always starts from a desire. So if practical reason always starts from a desire, then practical reason can't be objective. I mean, it can be objective in saying, if you want to do this, hypothetically objective, but it can't be categorically objective. It can say, if you want to do this, then you should need to do that. But since we have different desires, it can't say that, and it's objectively true for everyone, that they ought to do that. So if we think that ethics has to have reasons, has to be rational to make ethical judgments, you can't do that within Hume's framework. And it took quite a long time for me to accept that Hume might be wrong about that. And I think the clincher was an example by Derek Parfit, the Oxford philosopher I mentioned, who I knew quite well and I think was perhaps the most brilliant philosopher that I've known. His example was of somebody with a strange condition, a hypothetical condition, that he called future Tuesday indifference. So this is a person who's just like you and me in terms of hating extreme pain, and given a choice between mild pain, like a mild headache, or being tortured, would choose the mild headache. But he has this peculiarity that he doesn't care, he's indifferent about what happens to him on any future Tuesday. Right? So if you say to him, tomorrow you can choose, no, let me think this way. Okay, so you're saying today, you can choose between having a mild headache today or being tortured tomorrow. And he has to stop and think, what day of the week is it, before he can answer that question, right? Because if today is Monday, then he'll say, I don't care what happens to me on future Tuesdays, so I don't want to have the mild headache today, thank you. And so then he'll be tortured when Tuesday comes tomorrow. But he'll hate that because it's no longer a future Tuesday, it's a present Tuesday. So he'll suffer from being tortured just as any of us would. Now, this is a very bizarre situation, of course, but if we, it's contingent just the fact that there could conceivably be such desires, we can at least imagine it. And then on Hume's view, you would have to say that in saying, no, I don't want the mild headache today, although I know that I will be then tortured tomorrow, that he's acting rationally because he's satisfying his desires. He's acting to complete his desires. And that seemed to me impossible. And if that's impossible, then we can extend it, I think, maybe to other cases where we sometimes will acknowledge we're irrational ourselves. Like if we say, oh, my tooth is hurting me and I'm about to go away on a holiday to a tropical island, so I'm going to suffer more pain if I don't go to the dentist, but I hate going to the dentist, so I'm going to put off going to the dentist, right? So maybe that's irrational in a somewhat similar way. And then maybe judgments about, well, I hate pain for myself, but I don't really care about pain for you, so something that is a mild inconvenience to me, I won't put up with, even if that would prevent you being tortured for a long time. And maybe, this is the more speculative thing, maybe that's also contrary to reason in some way. So it was that kind of argument from Parfit. I was also, as I mentioned, Thomas Nagel, another philosopher who's taken that view with some influence. And I co-authored a book with a Polish colleague called Katarzyna de Lazari-Radek called The Point of View of the Universe. That's a phrase from Henry Sidgwick, a late 19th century utilitarian. And the book was really a study of Sidgwick's ethics. And he was an objectivist. He thinks that some ethical judgments are sort of self-evident rational axioms, including something like the two that I mentioned about the future and about others. So I think working through that book with Katarzyna and with the influences of Parfit and Nagel was what led me to change my views.
Hey Peter, thanks for that talk. I just wanted to follow on from your last slide about individual objection. I was wondering if you had any comments about institutional objection, particularly because in Victoria, the institutions are allowed to object to providing assisted dying despite the fact that it's a legal service, which can cause complications, particularly in really big countries like Australia where people don't have equal access to assisted dying. So I was wondering what you had to say about it.
Yes. So if the institutions are getting government funds, I think the government is entitled to say, we're not going to fund you unless you provide that care. If you are the only place that people can get that care, right? I mean, if if you know Melbourne well, St Vincent's Hospital in Melbourne, and you've got other that they won't provide it, that's a Catholic hospital. I think actually, I withdraw the statement they won't provide it. Maybe they will, maybe they won't. I'm not really. I've heard conflicting reports on that. But if you only have to go to another major hospital in Melbourne, it's a big city, not far away, and you can get it, I wouldn't try to coerce them into it. But if you're a regional hospital and you happen to have an objection to assisted dying, or to abortion for that matter, then it's much more questionable. Because if people don't want to travel if they're critically ill and they need assisted dying, they don't want to travel and they want to have their family near them, and that's difficult. In the case of abortion, I would say if it's an emergency abortion, again, they ought to do it. If it's a matter of, well, I could have it now or I could have it next week, doesn't make a big difference, then I don't think they should be forced to provide it.
Yeah, a follow-up to the first question. I wondered whether the change in your meta-ethical views had brought any practical difference in terms of your judgments about normative and applied ethics.
It did have one quite significant change. When I was not an objectivist, the view that I held was what's known as universal prescriptivism, which comes from R.M. Hare, who was, probably not coincidentally, my supervisor when I was a graduate student at Oxford. And so the idea there was that what we ought to do is to universalize everybody's preferences. And I won't go into the details as to why that followed from Hare's prescriptivism. But that meant that I was still a utilitarian, and Hare was a utilitarian, but a utilitarian where what you tried to maximize was desire satisfaction, satisfaction of preferences or desires. Once I was an objectivist, I had possibilities of considering other things as intrinsically good. And I ended up, again, sort of after discussions with Katarzyna de Lazari-Radek, and also still, this was Sidgwick's, the work on Sidgwick as well, I ended up going perhaps back to, because I think maybe very early on I'd held this view, the classical or hedonistic utilitarianism, where what you're trying to do is to maximize happiness and minimize suffering rather than satisfy preferences.
Okay, I have a question about embryos.
Sure.
You said that one perhaps religiously motivated objection to the creation of embryos for the purposes of doing IVF is that it would involve the deliberate creation of embryos that would either be destroyed deliberately or that would necessarily die. And the response to that was, spontaneous miscarriage happens anyway, so there's no morally relevant difference between what happens, as it were, naturally and this deliberate creation of embryos. Do you think that that's a good argument, or do you think that there could be a morally relevant difference between those two types of events?
Yeah. So, I mean, the question is, you might say, well, the loss of the embryos is going to happen anyway, and we don't want to add to it. The counter to that is to say it's not going to happen anyway if people abstain from sex. Then you don't have any embryos to miscarry. And then the counter argument to that is, well, but if people abstain from sex, the species will become extinct. And so you would have to say it's a benefit that children are being born. But then that's also true with in vitro fertilization, although it's not true that the species will become extinct because most people can conceive without it. I mean, the interesting thought experiment would be, suppose that there was some virus that spread through the world so that nobody could have children except through in vitro fertilization, and you were still going to have the embryos dying. Then I think the differences would disappear, actually. Then I think you would have to accept it under those circumstances. But you might say, well, as we're not in those circumstances, there is a difference. But personally, I wouldn't put a huge amount of weight on it.
Okay, thank you very much. Let's give a final round of applause for Professor Singh.